Okay, there we go. Can you still see the shared screen? Can you see the slides?
Yes.
Great.
Yeah.
Okay, I'll hand you over to Hisham then.
So, care of the central lines of neonate. Most of the information in this presentation taken from the document released by the British Association of Perinatal Medicine in 2015, updated in 2018, also from the local guidelines in Leicester. So the contents include the indication, contraindication, consent, the lens, how to measure the lens, and how to verify the position, and how to look after this slide. Consent. For central lines, like any other procedures, it carries risk of complications. So parents need to know about the risk of complications, and it shouldn't be a signed consent. It can be just verbal, and better to be prior to the insertion of the central line. However, in some situation, you wouldn't be able to tell them before the procedure. So you can retrospectively explain to them. So that's acceptable in terms of the consent. So we'll start with the umbilical lines. A little bit of anatomy about the umbilical vessels. So start with the umbilical vein. So this is the umbilical vein here. As we can see, start from the umbilicus. It's a short vein. It's between 2 to 3 centimeters. And on the way from the umbilicus to the inferior vena cava, there are 2 crossroads or 2 roundabouts, whatever you call it. So from the umbilicus, it goes anteriorly and upward. And then the first roundabout is the portal veins. So this is the left portal vein, and this is the right portal vein, and this is the main portal vein. So it should contain second exit. So straight to the ductus venosus. So this is the ductus venosus, which start to go slightly posteriorly through the liver, and then upward to meet the second crossroad, which are the hepatic veins. So again, we continue straight to the inferior vena cava. We need just to have an idea about the vertebral levels of these landmarks. So the portal vein at the level of thoracic vertebrae between 11 and 12, the hepatic veins at the level of thoracic vertebrae number 8, because that's how we're gonna verify the position on X-ray. Regarding the umbilical artery, the course is a little bit different. So instead of going anteriorly and upward, it goes downward and posteriorly, as we can see here, towards the internal iliac artery. So it joins the internal iliac artery and then go upward to the external iliac artery and then the descending aorta. There are 2 areas important in the descending aorta. The first area is between L1 and L2, where the inferior mesenteric artery arises to supply the bowel. The second important area is between thoracic vertebrae number 12 and the lumbar vertebrae number 1, because there are a group of arteries here supplying the bowel and the kidney: celiac trunk, superior mesenteric artery, renal artery. So you would want the tip of the UEC to be either above this group or between those groups, so it doesn't interfere with the blood supply of the important structures. On the X-ray, as you can see, you can easily differentiate. This is a lateral view X-ray, just to show the difference in the course of the umbilical catheter. So obviously the UEC goes down and then upward, and the UVC goes straight anteriorly and then upward. Measuring the length of umbilical catheters. That's in every guideline, so that's something I know. I'm sure everybody knows by heart. There are few methods for calculating the distance. I mentioned 3 of them here. The most traditional one was the umbilicus, measuring the umbilicus to the shoulder, and then plot this on a chart. The other one is umbilicus to the nipple and subtract 1. That's used in New Zealand. The third one in our local guidelines is using the weight formula. However, there is something important here. Number one, most of these methods were based on that you would want the tip of the UVC in the right atrium. You accept it in the right atrium. Clinician used to accept it in the right atrium in the past, but nowadays it's not safe to have the tip in the right atrium. So again, the X-ray verification is critically important for verification of the position. The other thing is there is no evidence to make any of these methods superior to the other. So the good thing is every unit has to adopt one of these methods and try to make all the stuff compliant with this method. Then they can audit it and correlate this with the X-ray position on the X-ray. They know how accurate is this method, rather than doing this according to individual preferences. Positioning of the UVC. Number one, what's the definition of central line? Definition of central venous line means the tip is either in the inferior vena cava or superior vena cava. If the tip anywhere else, it is not a central venous line. It's something else. The typical position for the tip of the UVC is between T8 and T9. So if you look here, so this is 12, 11, 10, so here at T10, T9. Another way of, another landmark to know the good position is just ½ centimeter above the diaphragm. So that means the tip is in the junction between the inferior vena cava and the right atrium, and this is the most proper position. If it is below T9, then there is a risk of extravasation into the liver. If it is above T8, it means it is in the right atrium and carries the complication of being in the right atrium. It has to be flushing and withdrawing blood. Otherwise, we know that we are in the wrong position or wrong direction. If it is not withdrawing blood, we have to pull it back until we get free flow of blood. And then we X-ray and verify the position. In emergency situation, we don't make all these calculations. We just advance the UVC until we get free flow of blood. And then we can use it to administer emergency medication. And then after the resuscitation, you can verify the position and act accordingly. for the positioning of the umbilical artery, as we mentioned before, there are two areas we need to avoid. So the high position is, we mentioned that this area is T12 to L1. So if we go up between T6 and T9, we will be safe. So the tip of the position will be in a good position. Some people accept it at T10, but the ideal is 6 to 9. Low position is between this group and the inferior mesenteric. It's between L3 and L4 because the inferior mesenteric arises between L1 and L2. So we need to go slightly below that. However, the high position is much less in terms of the complication. So it's much better to keep it in a high position. Unless you can't advance it more, then keep it in low position, but you will need to keep an eye on this line. Again, it must be flushing and withdrawing blood. On the bottom here, there is a question about what are the warning signs of UVC and UEC malposition. We will answer this question in the next slides. So this X-ray showing there is a UVC. You can see the UVC here is going in the wrong direction because at the level of the tip stops here at the level of T10 and is following the right portal vein, this direction. You see some gases here in the portal venous circulation. This is not unusual to see some air in the portal venous circulation with insertion of umbilical vessels. That's quite normal. It doesn't mean there is NEC. In NEC, the situation will be different. There will be gas on the bowel wall as well. That's magnification for the position. So normally the UVC should go up, as we said, straight up to the ductus venosus and then continues the pass through the hepatic veins and to the inferior vena cava. What happens here at the level of the portal veins deviated to the right side. So probably this one is in the liver parenchyma. There is also a UEC. So UEC, as we see here, going down first, as we said, going down and posteriorly, and joins the internal iliac, and then goes up until the level of T9. So that one is in a good position. Is this slide clear to everyone?
Yes. Yeah.
That's a question which I personally don't know the answer, but it's open questions about how accurate or reliable is the X-ray in verifying the position of the umbilical lines. Why I'm asking this question? For example, if we look at this X-ray, so this X-ray, the tip of the UVC is in the right atrium, because if you look at the level, it's gonna be above T. So what? So T8 or above. So it's in the right atrium and it is within the cardiac shadow as well. So by X-ray, I would say this is the tip in the right atrium. When they did echo, short axis echo for the same patient at the same time, so they found the UVC. You see the UVC, this is the UVC. is going from the right atrium along the atrial septum to the left, far to the left atrium. So what we can see on the X-ray in the right atrium was already in the left atrium. And that made few studies comparing between the X-ray and the echo. For example, there was a study done in the US of 50 preterm patients who had UVC placed, and then they did X-ray. So 49 of those had the tip either in the inferior vena cava or in the right atrium. When they echoed these babies, they got 25 babies of those, the tip in the left atrium. And there are other few studies making comparison as well, and showing that there is discrepancy between the echo and X-ray. The problem with the echo is you need staff to be expert. They have the experience to operate the echo in order to verify the position. Some places, like in St. Peter, for example, they use the echo. They don't verify the position with X-ray. They verify it with echo. Complication of central lines. There are hundreds of complications of central lines, but the main 4 categories of complication are: number 1, infection, the most popular one, and the incidence of infection with central line is very variable according to every unit. The level of compliance with the infection control policy, demographic of the patients. So it ranges, according to many studies, between 5% to up to 45% of patients with central line get infection. The second complication is extravasation. That is a rare complication, but it can be fatal, very serious complication. Fortunately, it doesn't happen frequently. And the complication depends on where the extravasation happens. So if it happens in the liver, it can lead to liver abscess. If it happens in the heart, it can lead to cardiac tamponade and can be fatal in this situation. Equipment failure, which means breakage or blockage or migration of the central line, or accidental removal. Accidental removal usually happens more with the long lines rather than umbilical and surgical lines, because the umbilical and surgical line are usually secured with stitches. However, the long line is just fixed with dressing. And then there are few specific according to the type of the catheter and location. So for the UEC, the most important one is ischemia. If it affected any of the important arterial supply to the lower limb or the bowel. So if it gone in the wrong direction, gluteal artery, for example, it can cause ischemia of the lower limb or the gluteal region, and in the severest form, it might lead to losing a limb, a complete limb. So that's a very important complication. Also, bleeding. Bleeding happens with the UEC usually during the removal of UEC, although that should be a smooth procedure, but sometimes it turns to be a big drama, particularly with extremely preterm babies, because they may lose a very high volume of blood in few seconds, and that leads to collapse of them. I personally had this incident in 2011, and the baby needed full resuscitation, including cardiac chest compression. fortunately had urgent O negative blood transfusion, and the baby recovered later on, but it was a very big drama. So bleeding is important. Neck, the UEC, if it interferes with the mesenteric arteries, it will lead to decreased blood supply to the bowel, and that will increase the incidence of neck. So some clinicians will advise not to feed babies with a UVC, with a UEC in situ. Regarding the UVC, so the specific complication of the UVC, number one is the portal vein thrombosis. You will be surprised to know that the incidence of portal vein thrombosis with UVC is very high, up to sometimes 1/3 of those with UVC will have this complication. However, because the symptoms and signs do not appear during the neonatal period, so they don't get diagnosed during the neonatal period. The other thing, some studies showed that the majority of these thromboses will resolve on its own. So that's why we don't feel like it happens very frequently, but actually it happens. Hepatic injury, if it extravasated to the hepatic tissue. Arrhythmia, if the tip in the right atrium, there is a risk of arrhythmia, and that's why we no longer accept the tip to be in the right atrium. NEC, I don't think NEC will increase with the UVC, it's more with the UEC. But in the textbook, you will find this one is included. So that's a slide for contraindication for inserting umbilical lines. There is no absolute contraindication for inserting umbilical lines. It has to be a kind of balance between the benefits and the risk. So gastroschisis and exomphalos, if there is infection around the umbilicus, although I can't see any stump here, so either way we cannot put umbilical line here. NEC, also another contraindication, although again that's not very practical, because NEC usually doesn't happen in the first week, usually happens second or third week. And by the time it happens, the umbilical stump will have separated, so there is no way to put umbilical line. But theoretically, if there is NEC, you don't put umbilical lines. And then we go to the long lines. That's a map for the sites we go for to insert long lines. The vein of choice is the basilic vein. You see this one running along the medial side of the arm. Why we like this one? Because number one, straight to the subclavian, short course, very superficial, shallow angle of insertion. So, and it's very wide. So if this is a brand new baby, hasn't been touched before, please try this one first. The second one we like is the long saphenous vein. Long saphenous vein can be approached just above the ankle, or you can try it in the thigh here, if there is, if this one was used. There is also the cephalic vein, which runs along the lateral side of the arm, you see. But the problem with this vein is it's narrower than the basilic and sometimes tortuous course, and it has a longer course. So is a second choice. So if you can't do it here, you can do it there. And this connection, we call it median cubital vein. This vein also superficial and wide, but the problem with this one is very close to the brachial artery. So there is a risk of cannulating the artery instead of the vein. If there is no chance with the limbs, you go for the scalp. So that's the one we use in the scalp, is the superficial temporal vein. It's a good vein, it's a wide vein, superficial, easy to access, but the problem with this one, again, just in front of it, there is the temporal artery. So there is a risk of cannulating the artery instead of the vein. There is a small vein here, frontal. I personally don't like this one because it's a small one and usually ends in the eye area. So I wouldn't advise doing this one. To calculate the length of the desired length of insertion, so it's very simple. It is for the upper limb between the site of insertion to the sternum notch. Lower limb from the site of insertion to the Zeef sternum. For the positioning of the long line on the X-ray, so 3 rules. Number 1, the tip has to be outside the cardiac shadow. That's number 1. Number 2, if it is upper limb long line, it has to be above the level of T4. Number 3, if it is lower limb long line, it has to be below T9, preferably between T9 and T11. We will say why. This diagram showed the upper limb. So what happens is the axillary vein continues here, meet the cephalic vein and continue as the subclavian vein. The subclavian vein drain the upper limb, will meet the jugular veins, which drain the head, and they form a brachiocephalic vein. So this junction happens just behind the junction between the clavicle and the sternum, and then pass down in the first intercostal space as brachiocephalic, where it joins the brachiocephalic from the other side, this one, in the first intercostal space. In the second intercostal space, it becomes the superior vena cava. So the superior vena cava starts from the level of T3 to T4. So that's why we like the tip of the position to be above T4. Regarding the lower long lines from the lower limb, so why we like it to be between T9 and T11, because this is the widest part of the inferior vena cava. So that's why this is the most preferable position for the tip of the long lines from the lower limb. There is something called short long line. Short long line is a long line with the tip in a big wide vein, but not superior vena cava or inferior vena cava. This one, theoretically, it shouldn't be used for more than 24 hours unless the consultant sanctioned the use of this long line, because there is no other access and this may be difficult to get any other long lines. in this case, because there is a risk of complication, you will need to add this to the problem list. So every day you just remind the team that we got a short long line with the risk of complication until we get a chance to take it out. The third thing is invisible tip. Invisible tip means in a wrong position. But before we say that, in the past, we used to use contrast for when we insert long line. We used to use contrast to see the course of the long lines on the X-ray. I remember I used to do that in Bristol in 2012 for all long lines, even the premicath ones. However, nowadays no one uses the contrast because they think the advances in the PACS technology, you can play with the contrast, so you can see the long lines without adding contrast. However, if you can't see the tip, by all means, you can try to give it a dose of contrast before you take it out, because it might be in a good position, but you can't see it because the premicath is very, very thin. So sometimes, if the quality of the X-ray is not perfect, you might struggle to see the tip of the long line. A rationale for position recommendation. Why we like it to be in the either inferior vena cava or superior vena cava? Because number one, the width of these veins, the speed of the blood flow very high. That means the long line will stay parallel to the blood flow, and the tip will not get a chance to stuck to the wall. And also, any solution running in this long line will be diluted very quickly and distributed to the rest of the body in few seconds. That's why in emergency situation, if you have a long line in a good position, using the emergency medication through the long line will be the best way to get a quick response. But it has to be in a good position. If we look at those X-rays, so those X-rays showing some short, long lines. This one in the upper limb, as we can see, so going through the axillary vein and then joint subclavian and then brachiocephalic. Normally, it should cross the midline to join the left, to join the right brachiocephalic, and then goes down to the superior vena cava. Here, the tip stopped here, just at the beginning of the left brachiocephalic. So that's a short, long line. For the other X-ray, there are two lines. So the first line here, I don't know whether you can see it or not, but there is a very tiny long line here, ends just above the femur. So it hasn't even crossed the hip joints. So that's why, so that's a short, long line and in a very dangerous position because it is inside the joint. That's why they put a femoral one. So this femoral is in a good position. Is there any landmark for positioning other than vertebral levels? Some people say that the carina for the superior vena cava starts 1.5 vertebrae below the carina. So you shouldn't go deeper than 1.5 vertebrae below the carina. The other landmark is the diaphragm for what's coming from lower limb. If the long line coming from the lower limb, then at the level of the diaphragm, just at the level of the diaphragm or slightly below the diaphragm will be okay. When we X-ray, the technique for doing the X-ray is quite important because the position of the tip will change with changing the limb position. So this X-ray for one baby, and this long line is going through the basilic vein, the one running on the medial side of the arm. As you see, while the arm is abducted, the position of the tip were in the midline here. When they changed the position of the arm and made it abducted, the tip has gone down to the right atrium. So the recommendation is, if the long line is inserted through the basilic vein, the best position when you X-ray this baby is to keep the right arm adducted with some flexion of the elbow in order to see what is the deepest length of this long line. For the lower limb, the best positioning for the X-ray is to have slight flexion of the hip and the knee. Then you get the deepest position of the tip of the long line. So these are the warning that we are on the wrong position. Number one, during insertion, if you face difficulty advancing the long line or the umbilical line, so that means we are going in the right direction. Probably the line has deviated into a smaller vein, so that's why you're struggling to advance it. Invisible tip, we talked about this before. On the X-ray, if you see any kinks or sharp deviations, that means the line has deviated to a small branch or deviated to the wrong direction, because we are aiming big straight veins. So deviations mean we have gone through the wrong direction. If the tip in a joint, that's a very risky position. Why? Because the joints contain the highest number of venous tributaries. So it's very easy that the line can go through any of these small tributaries, and that will lead to extravasation later on, because these are very small, tiny veins. So it's not acceptable really to have the tip left in a joint. If you insert a line in the left leg, it has to cross the midline to go to the inferior vena cava. If it continues straight up without crossing the midline, it means it has gone through a wrong direction. And we will show this in the next coming slides. If not flushing or withdrawing, or if the infusions are ineffective, like having a patient with hypoglycemia, and this hypoglycemia is resistant despite of increasing concentrations and volume through the long line. So we have to keep in mind that the long line could be the reason, because in a wrong position. So this diagram shows, when I said that if you put a long line in the left leg, and then it has to go up to join the iliac veins, and then cross the midline to ascend in the inferior vena cava. If it didn't cross the midline, it means and continued upward like this, it means it has gone through lumbar veins, as you can see. And lumbar vein is very dangerous as well, because lumbar veins can cause paresis. It will affect the spinal cord very seriously. And there are few case reports about having the long line in lumbar veins, and that was diagnosed after the baby had a paresis, sudden paresis of the lower limbs. And after a long investigations, they eventually knew that the long line running in the lumbar veins. This one, if you look at this one here, you see the long line here is going stopping in this area. So that is not acceptable, because stopping here to the left of the midline, it means it has gone through one of these lumbar veins. There is also umbilical art. There is UEC here, but it's in a good position. Inadvertent placement in an artery. There are three risky areas, as we mentioned before. So in the head, the superficial temporal vein, just in front, there is the temporal artery. In the arm, median cubital, just close to the brachial artery. In the foot, the long saphenous start in front of the medial malleolus. The posterior tibial start just posterior to the medial malleolus. There is a reasonable distance between them, but it happens. This complication happens. I personally saw a long line inserted in the posterior tibial artery and went through the arch of the aorta. How do you know that you have gone through artery? There is pulsation of the blood. If you raise the line like this, you will see the pulsation of the blood. Blood gases, looking at the PO2, because the PO2 will be higher in the arterial blood, and blanching of the skin and limb distal to the artery. So all these will tell you that there is a risk that you have gone through artery. So this X-ray on the right side, you see here, so this long line going through the left side, as if it was going through the axillary, brachial, brachiocephalic, and then rather than crossing the midline to go to the superior vena cava, what happens here? It went down straight, just left to the midline, and fortunately, here we knew that this is an arterial line rather than long line, because this baby already had a UEC. So the long line came from up and went down parallel to the UEC in the same descending aorta. So we had two lines in the descending aorta now. The other X-ray showing a long line inserted in the posterior tibial artery. So going from here, when they X-ray, they show the line going from the posterior tibial and then continue up. Again, contraindication for lower limb, for long line insertion. There is no absolute contraindication. It very much depends on the situation. Most of the clinicians will not like to put a long line if the baby has bacteremia or sepsis. If the area you want to put a long line in, there is burn or trauma or previous thrombosis, if there is anatomical irregularities, or blood coagulopathy. So these are relative contraindication. The fixation, everybody knows how we fix the long lines. Just a very quick reminder that for the long line, we coil the long line in circles, and these circles shouldn't cross the long line itself, otherwise it will lead to obstruction. And these circles will be fixed by steri-strips. And most importantly is the duoderm. You have to put duoderm just underneath this hub, because this is the connection between the long line and the extension. So you need to put a piece of duoderm, or sometimes people put piece of gauze or anything just as a barrier between this plastic piece and the skin. And lastly, you need to cover with Tegaderm all of this. So you need to cover up to here. So this part need to come under the dressing. For the umbilical lines, this is the local guidelines here. So you fold over the ends of this tape. You fold it to make it easy later on if you wanted to open it, and then you thread the stitches and the line. You stick them to the tape, and then you loop this line down, and then you close it, and you make this to the UVC separately from the UEC, so everyone will have its own securement. The ongoing care of the central lines. That means after putting the central lines, how we gonna look after these central lines? The most important of this care is, number one, to guard against the common complications. We mentioned before the common complication is infection. So how to guard against the infection? Stick to the local guidelines, the infection control, reduce the frequency of accessing the long line, and also review the indication for having the long line in situ every day. Blockage can happen because of thrombosis or perforation of migration of the long line. Migration is quite important, particularly if this long line stayed for more than 2 weeks, because babies will either increase in size and gain weight or lose weight with time. So every 2 weeks, if the line stayed for more than 2 weeks, the proportion of the body will change. So you might find the tip in a different position. So just keep this in your mind. So reviewing the position of the long line regularly is quite important. Early identification of the complication. Any baby with central line and having deterioration, sudden deterioration, think about the complication of long line. Daily check, we need daily check. I will let Sufi talk about what we should every day check on the long line. Opportunistic care. Opportunistic means that every time we do X-ray or ultrasound for any reason other than the long line, just check the position of the long line in this X-ray or ultrasound. Management of complication. So complication, the management is just according to what complication we got. Documentation. Documentation Most of the units will keep sticker. This sticker contains the points where you need to fill up after putting a long line or reviewing a long line. So that will include, number one, date and time, indication, any adjustment to the line, verification of the position on the X-ray, whether that was reviewed by the consultant or not. By the way, according to the guidelines, the consultant, neonatologist or pediatrician or radiologist has to verify the position within 24 hours. So these are the things you need to document about the long line. Removal of the central venous catheter. That's a smooth process, but it can turn to be a big drama, as we mentioned at the beginning. If you lost the focus for a second and, for example, you were asked to take the UVC out and leave the UEC and suddenly snapped the UEC, so that might lead to massive bleeding. The other thing is the long lines. If you pull the long line very forcefully, that might lead to breakage of the line and missing part inside the baby. That is extremely difficult to manage. And there are few case reports where we lost, where there were missing part of the long line and the circulation, and even the cardiothoracic team, they were unsuccessful to get it. Eventually, only the intervention radiologist were able to get this missing part out. So soak the dressing in Appeal. Use as much as you can. Give it time until it loose. Then be aware of the length of the long line. Then you make sure when you get it out that you got all the long line. Look at the tip. The traction side. You pull the long line just 2 to 3 centimeters above the point of insertion. Gently, consistently, and if you found any resistance, don't pull it forcefully. You can try to flush it with saline, because sometimes it's going through a small vein. Then when you flush it, that will inflate the vein, so it will make it easier to pull the long line out. You send the tip for culture and sensitivity if there is any suspicion for infection, and eventually hemostasis. You press on the site to stop any bleeding. Usually there is no bleeding because the long line stays for a long time, so most probably the vein has fibrosed. So this is the part for you, Sophie.
Okay. So nursing care of central lines. Just following on from what Hisham has said. So documentation for transfer before you go anywhere with the baby. It's important to make sure that you have checked the position of the X-ray yourselves as the transport team and documented that in the notes. There is a picture in our transport notes that you can use to identify where the lines are and document the length of those. It's also important to document how many centimeters the line is in at as well, so that you can check in case the line has moved during the transfer. Check that any line is secure, so the long line, check that the dressing is secure, and for umbilical lines, check that they're also secure with the sutures and the tape. And if you're using umbilical line, venous or arterial, ensure that you have a cord tie around the cord before you transfer the baby, so that you can pull that tie in case of emergency, in case the line comes out and there's any bleeding. You have a way of stopping that bleeding. That's not something that we often document on our transport charts, but it is a good idea to document that, so it's clear that you had that tie in place. and make sure that you do have it before you go anywhere with the baby. We do have a spare tie in our black bag if for any reason the one that you have didn't work or you lost it during the transfer. I'm just going to read this slide now that you can see. This slide was written by Hannah Burton, one of our transport nurses, but unfortunately she couldn't be here today. So general care and documentation of any central line during transfer. Before we go in the ambulance, we can do our observations hourly, as the unit do. During transfer, we need to do these observations every 15 minutes. So that will be your VIP score, your visual information and phlebitis score that we do for all central and peripheral lines. Observe the site for redness, any oozing, swelling, phlebitis or tracking. If you notice any of this, then you need to give the site an extra check to make sure that everything is still okay. Follow the VIP score chart that is within our notes for guidance on what to do based on the VIP score or any phlebitis or tracking that you see. You need to double check if the dressing is clean, dry, if it's peeling. Also check for long lines that the dressing doesn't go around the whole arm or around the whole leg, because that could potentially cause problems for the baby. So we need to make sure that the dressing doesn't meet itself. So if you have a thin arm or a thin leg, that the dressing doesn't go around the whole arm, that there is a free space there so that the arm or leg doesn't get swollen. And finally, we need to observe and document the line pressures. So we do this for all of our peripheral lines as well, but document that pressure. And if you see an increase or decrease in pressure that is unexpected, then that will be an indication to have a look at the line. The line may need a flush. As well as those observations that we do with our documentation, we also need to be doing some visual observation of the lines. So continuous observation of the lines when you're with a baby. Make sure that you can see the line. So if the baby has a long line, for example, you want to make sure that that line isn't covered by clothing so that you can see it during the transfer. Ensure that you've got ECG monitoring in place. Ensure that for a UAC, you're continuously observing the lower limbs. So make sure you're looking at the toes, feet, legs and buttocks, checking the capillary refill, and making sure that if there is any change in the trace, so if you can't get a blood pressure reading or the trace is looking different, that you your lines. For venous lines, you need to be looking at the abdomen and the legs as well. So you're not going to be checking for the capillary refill, but you're going to be looking for colour change. So any colour change on the abdomen, any swelling on the abdomen, that may be an indication that there is a problem with the venous line. For long lines, you're going to be checking that particular limb. So if the long line is in the arm, then you're going to be looking for swelling or discoloration in that particular limb. And then finally, documentation, as we've said, so writing down your VIP score, writing down that you've checked the sites and that you've written down your pressures. If you have noted that there are any changes, you need to document what that change is, and you also need to document your action. So if you come up with a problem and you have fixed that problem, you need to document the action that you took. Back to you, Hisham.
So the last thing, just a few X-rays before we finish. So this is the first X-ray, showing a UVC with far destination. So UVC going here, so right atrium, and then pass through the foramen ovale, and then to the left atrium. And the other one has gone the same way, and then from the left atrium to the pulmonary vein of the left upper lobe. This X-ray, so the UVC here was going through the umbilical vein and suddenly deviated to the left side. So what level this happened? So this is, if we start to count 1, 2, 3, 4, 5, 6, 7, 8. So actually, deviated through the left hepatic vein, this one. So some people manage this situation by pulling the UVC back until it is in a lower position, lower straight position. I would say for a low position, it should be used for a very short period until you either get another UVC inserted or to get a long line, because there is a very high risk of extravasation into the liver tissue. This one, the UVC has gone here. So umbilical vein going up until the portal circulation, and then it coiled and then went through the right portal vein and then went down to the portal vein again. If you just to go back to the anatomy of the UVC, yeah. So that's exactly what happened. So the line has gone this way and then coiled at this area and then passed down through the portal vein. Yeah. So this you see in a low position, this one. So this one, we got a UEC in a low position, and there is a UVC. Look at the UVC here. So UVC is going through the umbilical vein, ductus venosus, inferior vena cava, right atrium, superior vena cava, and then jugular vein. And I don't know, we can't see the tip.
Wow. How long is that line?
How small is the baby?
Yes, it must have been a small baby.
Yeah.
Wow.
I probably was very excited about this.
Somebody was.
And this one, this UVC has obviously turned in the portal vein and has gone down to here. So I just wanted to know the number of this vertebrae. So this is L1, L2, L3. So that's probably the mesenteric vein, superior mesenteric vein. Yeah. So anyway, this is the wrong position. So this UVC also, we have seen this one before. This is for the UEC here. So the UEC has gone, so inserted has gone down as expected to enter the iliac, internal iliac artery, but instead of looping up and going through the descending aorta, it looped down and went through the gluteal artery here. So you see the UEC. So that is, this one needs to be taken out. This one is, the quality is very bad, but the UVC has gone to the right atrium and then passed through the foramen ovale and then coiled and passed through the left atrium to the right upper pulmonary vein. The UVC here, this is the umbilical recess. Do you remember when we said the umbilical vein goes up until it meets the first crossroad is the portal vein? Just prior to joining the portal vein, there is a small cavity of the umbilical vein. We call it umbilical recess. The problem with this recess is there is a chance that the catheter will get coiled or looped in this area, and that's what happened here. This one also has gone through the umbilical recess and then looped retrograde, so it's going back to the umbilicus. That is UEC, as we see. So UEC has gone up to, so UEC here, inserted here. So it's gone down and then went up through the descending aorta up to the subclavian artery, probably. The UVC here in the liver parenchyma. This is one of the important X-ray. Why? Because there is a, I hope you can see this long line. Do you see it, this one?
Yeah.
So there is a long line here. So if you follow this long line, you will find that it has gone suddenly looped. You see this? So we previously said if you saw any sharp deviation or kinks, then it means in a wrong position. So when they did lateral X-ray and they looked at the same line, so they found that the line has entered the spinal cord. So any sharp deviation or kinks means in a wrong position and can be in a serious place. This is a long line from the left upper limb going through the superior vena cava and looped, and then going through the superior vena, going up through the superior vena cava again. Oh yes, we got here a long line here, if you can see it. So has gone through the upper limb, axillary, subclavian, and then it turned, it looped laterally to go this way. Most people in this situation, what happens in practice is they pull the long line until they get it in one of the bigger veins, the brachiocephalic or the subclavian. So I don't know whether this is something is a good practice or not, but it is. If it is in the if you left it in the subclavian, then it's not a long line. There is risk of extravasation and thrombosis. So this long line from the right lower limb is going up through until L1 and then defeat this way. So when you look at the lateral view, you will find this kink or deviation. So that was in the renal vein. So any kink or deviation or sharp deviation, it should be, it is a wrong position. Here also there is some kinks, and when the X-ray was repeated, it wasn't very obvious in the first X-ray. When they repeated the X-ray, it was very obvious here. So rather than this long line coming from the left leg, it has to cross the midline after the hip joint in order to go and join the inferior vena cava. It didn't. It kinked, it changed direction, and went this way, which means has gone through lumbar vein. It could be in the spinal cord. So when they did the lateral X-ray, they found already the long line is going through the spinal cord. So it's quite important that any long line going from the left leg to cross the midline after passing the hip joint in order to join the inferior vena cava. If it continues on the left side, it means it's in a wrong position. Yeah, and that's last X-ray. Thank you.
All right, shall we see if anybody has any questions? Does anybody like to ask anything to Hisham?
No.
Okay, so I did have a couple of questions come up in the chat, and Artie has so that she's had to leave, but there were a few things that she wanted to ask. So there was a little bit of a discussion between Artie and Kumar and Puneet about the safest position for umbilical venous lines, and it says that the question is the safest position at T10 or just at or below the diaphragm rather than ½ centimetre above?
For the UVC, you say?
For UVC, yes.
Below T10?
So I don't know if anybody from these questions is still on this call. Is Kumar there or Puneet? Might be a better person to talk to Hisham than me.
So can you say it again, the best position is?
So the safest position for umbilical venous catheter tip is T10 or just at below the diaphragm. Has this changed?
Sophie, I think it's still on the floor.
Yeah, I can see that.
Below T10 or at T10? Well, the resources I read from, they said T10 or below, the risk of extraposition is higher. That's my resources.
I think the practice on the unit here is to be just slightly above, so you definitely know that you're not gonna, if it pulls back slightly, you're not gonna be going into any of the static veins, and it's not gonna extravasate. So, because you know that you've still got a little bit of space above the diaphragm before you go into the right. There's still, sorry, the superior, into that. So it's not going to be.
And ½ centimetre above the diaphragm means
the superior vein,
the cavo-atrial junction, which is the best position for an line.
Okay, so it seems that maybe there's a slight difference in practice between Coventry and UHL policies. Okay.
Sophie, I don't think there's a huge difference. I think the idea is basically for that UVC to be as close to the cardiac cell height as possible. So it's of course it should not be way into the right atrium, and as Hisham rightly said, lower UVCs are associated with higher risk of extravasation.
Okay, that's great. Thank you for clarifying, Puneet. And then the other question was, Kumar suggested that he uses a short saphenous in difficult access, so that must be for long line positions. He also suggested a short saphenous can work well.
Yeah, we mentioned about this point. That's the short long line, which can be sanctioned only by the consultant.
Okay.
And it's a matter of balance between the risk and benefit. So.
Okay. And then the final one, there were a few questions about the positioning of the arm for X-rays for long lines. So Artie asked questions that she wasn't aware that flexing the elbow was beneficial, and some radiologists can suggest 90-degree positions of the shoulder joint. So certainly from a nursing perspective, I've never been told to bend the arm that I can think of. I don't know if any of the nurses have been.
I will tell you, for the basilic vein, if it is a basilic vein, you need to abduct the arm, because when you abduct the arm, you push the line to the deepest point. If it is going in the cephalic vein, it's in the opposite direction. When you put it in 90 degrees, then you push it to the deepest point.
Okay.
So you X-ray it in this position. I never did this before with the X-ray until I made this presentation. When I gone through reading about this, I found a few resources talking about this. So there is some X-ray to evidence to show that.
Okay, that's really interesting. Thank you, Hisham. Any other questions?
Just one comment, Sophie, if I may. You know, Hisham talked about putting lines into arteries by accident. Agree with the X-ray that he showed, which was very clear. Sometimes that doesn't happen. So your lines actually are short, short as in they go to the medial end of the clavicle and stay, and they don't bend. Arms don't blanch. And it's very, very, very difficult to find out whether this was an artery or a vein. The only way you can do is by the person who's inserting it with the amount of blood that comes through. So while those points are good and valid, it's important to remember that it might not be the case all the time. We've got a baby, I think, presently in Leicester at the moment, which has had a similar thing and has probably, I think, lost a little bit of fingertips and the proximal joint.
Yeah, I do agree. I do agree with this, and I have seen a long line inserted in the pituitary artery, went through up to the arch of the aorta, and was done by one of the experienced consultants in Bristol. We just knew that from the X-ray. So one of the best hand in long lines. So as you said, yeah, it's very tricky. It's sometimes very difficult to know. That's very true.
Any advice from anybody about what else we can do on transport if we're moving babies? That there's a question about the line position with UVCs as well and UACs. Any advice from anybody about what else we can do as a team?
Sophie?
I think.
Sorry, Puneet.
Carry on.
Sophie, I was going to say, if you were unsure of which line was which, could you transduce them to see if you got a trace?
Yes, absolutely. Yes, and that is something that we often do.
And I think also we may ask the radiologist if he can do ultrasound to check whether this is artery or vein. Some of them will be able to differentiate between the artery and vein.
Okay.
Would a Doppler help in that case? You could always use Doppler to see if your line insertion area is in a arterial vein if you're getting a pulsation.
Yeah. I've seen a case, the line was in the axillary artery, and they thought it's in the axillary vein, and the radiologist was able to see it very well in the artery.
I think Doppler's all good and a good thought. Not really helpful in the middle of the night in a level 1 unit in a tiny baby. So I think the important thing here to remember is when we take over the baby and we look at the line positions, we should be absolutely happy with the lines and their tips with where they are. I'm not saying they have to be into the millimeters perfection of where they should be, but at least we should be happy that we're using UAC as a UAC and a UVC as a UVC at least. And the lines are not in the heart. Couple of centimeters short UVCs for 1 hour, 2 hours, depending on the baby's condition, won't make a huge difference and should be handed over then to the receiving unit for the appropriate line positions. But the key thing is to be absolutely happy that those lines are there where they should be, and if not, then remove them and use peripheral access. And it all depends on the baby. You can't have just one rule for all kind of formula.
Thank you, Puneet. I'm just conscious of time now. We've run over a little bit. So if there aren't any more questions, I'd like to thank Hisham. It was a really detailed presentation with lots of work gone into it. So thank you very much.
Thanks, Hisham. Sophie, just as a follow-up for this, it's a good, interesting thing. Probably do a quiz, Hisham, get lots of x-rays, and a follow-up quiz in a month's time.
That's really input.
Just a thought.
Okay, we'll make sure
Annual leave that week.
test your memory on the conversation we had today, then, Puneet.
Absolutely. Oh, well, you can. Yes, definitely. Not a problem. Thank you all. Thanks, Hisham. Thanks, Sophie.
Thank you.
Thank you for everybody's input.
Thank you.
That's great.
Thank you, Hisham.
Thank you.
Bye.
Bye.
Right, I'll turn this.
Thank you. That was very good.
Well,